I'd like to invite Jérôme Razanamahery, who is from Dijon. He's going to speak about glomeruloid angioma.
Okay, thank you to the organization to let me present this work about glomeruloid hemangioma in a patient with ECD, which is an atypical skin manifestation associated with elevated VEGF-A level. When we look at the spectrum of ECD, we all know that it's a rare myeloid cancer with a lot of mutation described in the MAP kinase pathway, and it leads to apoptosis resistance and proliferation. And thanks to the data from the ECDGA registry, if we look at the proportion of the skin involvement in patient, it's in 26% of patients. Regarding the literature, which has been made by a lot of workers, so it occurs in about 20% of patients. The classical lesion is xanthelasma, but there is description of non-classical ECD lesion like patches, nodular, some with mixed LCH, and there is one case of glomeruloid angioma which was described by Paul Legendre. So this is the kind of lesion that we used to see in the patient with ECD in the clinics. Those are like non-specific, described by François Chassé, and it was the lesion that was described by Paul Legendre in a patient with ECD. So it's like a typical glomeruloid hemangioma with a vascular outgrowth, and it's described most in POM syndrome, which is cancer with neuropathy, monoclonal gammopathy, and elevated VEGF-A level. So we wanted to identify the frequency of atypical vascular-related skin manifestation in patients with ECD. So we look at the patient from Dijon, Paris, and Florence, explore the association of this type of lesion with VEGF-A level, and of course, excluding POM syndrome. So we could retrieve the data of 574 patients, and 32 patients had skin lesion, and among those, 5 patients had glomeruloid or extensive angioma. It was all men, median age of 64 years old, and organ involvement. It was a systemic disease with five organ involved, so mostly bone for all patients, cardiovascular system, and perirenal system. So if we dig deeper into the description of the patient, so for all the patients, as I said, it was systemic disease. Only one patient had a classical xanthelasma, and if we look at the mutational status, so 2 patients get MAP2K1 mutation, and 2 patients have a BRAF V600E mutation. And looking at the vascular outgrowth, it was nodular or papular for most of the patient, and the lesion were predominant in the trunk, but in one patient it was also in the head. And if we look at the VEGF level, we have the data for 4 patients, and it was elevated in all cases. And if you look at the CRP level, it was elevated. And of course, we have excluded a feature for POM syndrome in those patients. So the characteristics of the lesion, it was a reddish papule, it was painless, non-pruritic, and as I said, it's in the trunk rather than the head. And this is the kind of lesion that the patient have. And for this patient, he had really a lot of lesion in the trunk. It's the first patient who is 44-year-old, so it's not really normal to have those kind of lesion at that age. And there is a lot of lesion. This is a zoom of another lesion for a patient. And the last one got really outgrowth vascular in the head here, and there is another lesion here. So as I said, 2 BRAF-V6 secondary mutation and 2 MAP2K1 mutation. And if you look really at the type of lesion, there is some irregular aspect here that you can see on the glomeruloid hemangioma with dermatoscopic. And the patient, 2 patients got biopsy. So this is the aspect of glomeruloid hemangioma, but in the lesion there was coexistence with foamy histiocytes. So the patient, as I said, got MAP kinase pathway mutation. So for the treatment, 4 of 5 receive BRAF or MEK inhibitor. 1 patient was treated with interferon, and all got response on the PET-CT, but the response of on the skin lesion was for most stable, but for 1 patient there is incredibly efficacy of MEK inhibitor. So this is the patient that I present, and after 4 months of MEK inhibitor therapy, he got no more lesion. He got the same here in the back, and after MEK inhibition, there is no more lesion. So, as I said, all the patients got increased VEGF-A level, and we know that it's an important pro-angiogenic factor implicated in several cancers and leading to neoangiogenesis. So this is the implication of VEGF. It's implicated in capillary and vascular permeability and outgrowth of vascular and nerve vessel within the tumor. And we know that it's elevated in POM syndrome, which is an hematological malignancy with a bone lesion that can mimic ECD. And the most frequent skin changes in this disease is glomeruloid hemangioma. So if we look at the pathway, we know that there is activation here on the endothelial cell, and then there is activation of MAP kinase pathway and a possible AKT-mTOR pathway leading to angiogenesis. Julian showed earlier that you can have elevated VEGF-A level in the serum in ECD patient, which is associated mostly with vascular lesion, and there is a decrease of serum level after kinase inhibitor. So VEGF-A may drive possibly the type of vascular lesion in patient with ECD. So this is the first series of ECD patient with extensive or glomeruloid angioma. It is all male. 1 patient got xanthelasma. There is elevated VEGF-A level, which can mimic POM syndrome. Of course, we should exclude POM syndrome, consider ECD, and look for the cardiovascular lesion for this kind of patient. There is some limitation, of course, because it's a small retrospective cohort. We don't have a complete tissue biopsy on the VEGF-A analysis on all tissue, and aging can be a co-founder on the lesion interpretation. So to conclude, this kind of lesion can be a rare manifestation in ECD patient, likely driven by VEGF-A, and we have to consider ECD even in the absence of a typical skin lesion. So I want to thank all my collaborators from Paris and from Florence, and of course all the patients, and I'm happy to take questions.